Okay, I'm back. Now we're going to talk about, in chapter 67, we're going to talk about the cerebrovascular disorders. So this is anything that's going on in the brain related to the blood vessels that are in the brain. Basically, there's two things that can go wrong in the blood vessels in the brain. You can have an ischemic stroke, meaning lack of oxygen caused by a clot or an embolus or something like that, or you can have a hemorrhagic event, and it can either be a hemorrhagic stroke, a hypertensive bleed, or a ruptured aneurysm or AVM. Those are the two main things that can occur with a cerebrovascular event in the brain, also known as cerebrovascular accident, a CVA. We're going to describe that. This should be fairly short. So, in an ischemic stroke, and if you go back a couple chapters, I think it was in chapter 65, where you look at the arteries that are going up into the brain, it starts from your carotid arteries. You've got your internal and your external carotid arteries, and then it goes up into the brain, up through the circle of Willis, and all those arteries in the brain feed the brain the oxygen and nutrients, and that's where the carbon dioxide exchange takes place, just like in any other organ. In an ischemic stroke, what happens is something swims upstream and creates a block. That something could either be an embolus from plaque buildup. Oftentimes people will get plaque buildup in their internal carotid arteries, and a piece of that will break off and go upstream, and it will lodge in one of those smaller arteries. And when it blocks there, then no oxygen and blood can get beyond that, and it causes cellular death, ischemia, and that's when the stroke starts occurring. And so when the clot gets lodged up in there, and ischemia starts occurring in the wherever it's occurring in the brain, that's when you start seeing the patient will have numbness on one side of their face, tingling. They might not be able to smile. They'll have facial drooping. They might not be able to speak. They may have garbled words. They might have hemiparesis, meaning unusual feelings on one side. Hemiplegia, meaning they've got weakness and inability to move one side. So there's a lot of movement in the community now to increase awareness of stroke and the signs and symptoms of stroke. And it's really important to identify that somebody's having a stroke to get them treatment very quickly. When an ischemic stroke occurs, and like I was saying before, it can either be from plaque or from a clot, which is also called a thrombus. So this is why people that have AFib and a flutter, atrial fibrillation, atrial flutter, and they start developing blood clots in the ventricle, especially if it's coming out of that left ventricle, it's going to go up into the carotid arteries from the left ventricle. Now remember, if the clot is in the right ventricle, now it's going to go to the pulmonary system, and you're looking at a PE, a pulmonary embolism, and then you're going to have pulmonary problems. But if it's in the left ventricle, it'll go up through the carotid arteries, and that could lead to an ischemic stroke. So the ischemic stroke can either be an embolus or a thrombus, but essentially they're the same things. Essentially, it's some kind of debris in the artery, and depending on the size of the clot, will determine how severe the stroke is, because a larger clot is going to get lodged in a bigger artery, and then you're going to have a larger area of brain that is not getting oxygen and blood supply, in a larger area of ischemia. A smaller clot or embolus can swim further upstream, and you're going to have a smaller area of infarct. So when your patient, or when if you're out in the community and somebody starts displaying those symptoms, like I just mentioned, inability to smile, or when you have them smile, the one side just looks droopy, confusion, their words are confused, they're all of a sudden they can't stand up, they don't have strength in one side where they used to, need to get to the ER right away. When somebody's having an ischemic stroke, if you can identify it quickly and get them to the ER quickly, if you can determine that it's ischemic stroke, we have a medication now called recombinant TPA, also known as TPA, which is a very potent fibrolytic agent which will break down a clot, which is what you want to do, because if you can break down that clot very quickly, you can restore blood flow to that area of the brain and save somebody's life, or at least minimize the deficits resulting from the stroke. There are, however, certain criteria that you have to follow in order to give TPA. So step one, you have to determine what kind of stroke it is, because TPA, it goes in through the veins or sometimes in the arteries, and it's a very potent fibrinolytic agent, and it can cause massive bleeding, so you need to be very careful, and there's certain criteria. Step one, if you take somebody to the ER, somebody's coming into the ER and you think it's a stroke, you have to send them for CT scan stat. So this is why if you're working out in the field, you would call in, like the paramedics and the EMTs are trained to call the ERs and say, I think you've got a stroke victim, so the hospitals, the CT scans of the hospitals can get ready to receive that patient, because you can determine on CT scan if that is an ischemic stroke, meaning just lack of oxygen, or if it's a hemorrhagic stroke, meaning one of the vessels has actually ruptured, because you cannot give TPA to a hemorrhagic stroke because the patient will just continue to bleed and not clot, and you'll kill the patient. So step one, they've got to have a CT scan, and it has to be done within 3 hours. And there's certain criteria about whether or not you can give the TPA. I think it's in your book on page 1977, chart 67-2. You need to be familiar with that, because that's the criteria for, can I give somebody TPA or not. They have to be over 18 years of age. You've got to confirm that it's ischemic stroke. You do that through CT scan. They cannot also be on heparin or Coumadin. They have to have a fairly normal blood pressure. They have to have within normal limits PTT and INR levels, like their clotting factors have to be within normal limits. They can't have a history of GI bleeding. There's certain things like that. So if they meet that criteria, then you can give somebody the TPA, and it goes to all the vessels, but it will go to the cerebral arteries, and hopefully break down the clot and restore perfusion to the brain. That's the goal. When you can't give TPA, or even if you do give TPA there's still deficits, then you have to deal with the deficits of the stroke. And I'll talk about that in a minute. Because the deficits would be the same if it's an ischemic stroke or a hemorrhagic stroke. A hemorrhagic stroke, the pathophysiology is the same, because basically you're also not getting oxygen or blood supply to a certain area of the brain, but the cause is different. In a hemorrhagic stroke, an artery actually ruptures, and bleeding occurs, and that can occur from a variety of things. You can have an aneurysm. You can have an AVM, an arterial venous malformation, which is, I think there's a picture of it in here. Remember a couple lessons ago I showed you that AVM that my daughter has in her hand? It's like that, but in somebody's brain. Those vessels are very tortuous and very prone to bleeding. Those can occur. I thought I saw a picture of it in here. I'll find it. Or people that have long-standing hypertension, those vessels tend to be under a lot of tension and pressure, and those vessels can rupture. And so what happens, the vessel ruptures, and then you start getting bleeding. Those kinds of strokes hurt worse. The patient will often complain of like a throbbing, pounding headache, the worst headache of somebody's life. And oftentimes what a patient will do is, like, they'll grab their head, this is the worst headache of my life, and then they will either lose consciousness or start having some of the same symptoms that an ischemic stroke would have. And in that case, you also get them to the ER. The CT scan would show that it's a hemorrhagic stroke, and then the treatment is different. You would not give the TPA, depending on the size of the bleed. You could either clip the aneurysm. If the aneurysm is still bleeding, there's ways to go in and surgically clip that aneurysm, and so that no more blood can get up in there. They can evacuate the hematoma, so hopefully that the hemorrhaging vessel will clot and form a blood clot, and you can remove the clot surgically because you want to get the pressure, the blood off the head. If it's a small enough bleed, sometimes the brain can reabsorb it, and you would just do symptom management. Like we talked about in the other chapter, where you keep the patient calm and use steroids and osmotic diuretics and things like that. If a patient is known to have clotting in their arteries, especially in their carotid arteries, sometimes the patient can have what's known as a carotid endarterectomy, where they go in and surgically take out the clot that's inside those arteries. It's risky because now on one side of the brain you have to cease blood flow for a little while to get the clot out, the plaque out, and afterwards they're at risk for developing a stroke because a piece can lodge and go up there, or inflammation can occur. So patients who have carotid endarterectomies tend to have to go back to the ICU for observation, at least for 24 hours. On page 1979 in your book, it describes the procedure of having a carotid endarterectomy. Patients that have a hemorrhagic stroke, remember in the last chapter I told you about ventriculostomies and craniotomies? Those would be done following a hemorrhagic stroke to remove the clot, the hemorrhage that is in the patient's brain. Following any kind of stroke, there are often neuro changes, and the neuro changes can take a while to plateau out. In an ischemic stroke, usually it takes about 6 months until you really find out where this patient is going to be. In a hemorrhagic stroke, usually it takes a little bit longer for recovery, but the symptoms are going to have everything to do with where the stroke occurred. So if the ischemia was in the front of the brain, the frontal lobe, the patient may be more emotional, they may be more forgetful, they may have personality changes. If it's in the back of the head near the occipital lobe, they might have some vision problems. They can have vision on one side versus the other. There's a great table in here. Oh, another thing is wherever the stroke occurs in the brain, the symptoms will occur on the opposite side of the body. And the reason is because of the crossover of the nerves in the brain. So the nerves that are innervated on the right side of the hemisphere cross down and control the left side of the body, and vice versa. So if your patient has a stroke, like in the right parietal lobe, you're going to see symptoms on the left side of the body. So nursing care following a stroke is difficult but very specific to what the patient's dealing with. They may have bowel and bladder problems, they may have weakness or paresthesias, hemiplegias on one side or the other, and so the patient has to teach themselves how to eat, how to think, how to do certain activities. So oftentimes you have to get more members of the health care team involved. Physical therapy usually has to get involved because you want to prevent atrophy. Occupational therapy gets involved. And the occupational therapists are the ones that teach people fine motor skills, like how to rebrush your teeth, how to brush your hair. Some of the sequelae of certain strokes make it very difficult for somebody to understand what to do with certain objects. Like a hairbrush, you can hand them a hairbrush and they wouldn't know that they're supposed to brush their hair with that. And there's a lot of devices on the market now to help people, like if they're having contractures or paresthesias, there's different utensils that they can use that are easier to hold than like regular silverware. So look through your book about some of the nursing interventions following strokes, communication is a big problem. There's two areas in your brain, Wernicke's area and Broca's area. One is for, like Wernicke's area is for, to, like, understanding, for expressive aphasia, and Broca's area is receiving information. So one area makes you understand language that is being spoken, and the other area is responsible for making your words coherent when you're speaking to somebody else. So depending on where the stroke is, you may have either expressive aphasia, they're not able to express themselves, or receptive aphasia, they're not able to understand what's being said to them, which becomes very frustrating to patients. So in a situation where a patient has a communication issue, you don't need to shout at them. You can slow your speech down and try to use very simple yes-no questions. We're not going to give them a whole dissertation. We don't want them to use open-ended questions, just real simple yes or no. Okay, so on page 1988, this is where the different this is what I was talking about with the aneurysms. An aneurysm can either be a berry aneurysm, where it's just like a little, like the one, it just says an intracranial aneurysm. It looks like a little berry, so the aneurysm is there, and then there's like a little berry on top. They can just clip those. Some aneurysms are right in the artery itself and just kind of an outpouching, and those, they can wrap those with certain meshes so that they don't rupture again. Studies have shown that a fair amount of the population are born with an aneurysm, they have an aneurysm, and most of the time we never know it. I read one study that says there's probably about 30 to 40% of the population that has an aneurysm, but a very small percentage of those actually rupture. But when they do rupture, they can be deadly. When an aneurysm ruptures, if you can get the patient to the hospital and get the bleeding to stop and get the hemorrhage out of the brain, there is a phenomenon called vasospasm that can occur afterwards, because the vessels don't like to be manipulated, and so then usually about 3 to 7 days post hemorrhage, the vessels will start spasming. And during this time, it's really important for the nurse to keep those vessels open. But at the same time, if you remember, we don't want a lot of fluid. So this is when we give albumin and some of those volume expanders that don't add a lot of volume. So, you know, plasma and albumin and things like that help open the vessels, because when those vessels spasm, now all of a sudden I can't get blood through there, and now you're in the same situation where you're having like almost ischemic events where there's oxygen, blood cannot get beyond where the spasming is occurring, so you need to try to prevent vasospasm following hemorrhagic ruptures in the brain. Okay, the rest of it, we talked about increased intracranial pressure, which the hemorrhagic strokes are going to have high increased intracranial pressure, more so than your ischemic strokes, because the ischemic stroke is just lack of oxygen, where the hemorrhagic stroke is lack of oxygen plus additional fluid in the brain. So there's more, the hemorrhagic strokes tend to have higher increased intracranial pressure. Okay, so I think that's really about it for the cerebrovascular accident. So that's really what can occur in the vessels, the arteries in the brain. An ischemic stroke, hemorrhagic stroke. Hemorrhagic stroke can be an aneurysm, an AVM, and hypertension. Ischemic stroke can be a thrombus or an embolus. The outcomes are the same because it is brain cell damage because of ischemia. Treatment is slightly different. One is TPA, and the other one is surgery or an evacuation of a hematoma. But following that, then the recovery phase is about the same, and the nursing interventions are very similar. So, okay, so that's it. Skim through the chapter. Let me know if you have any questions, and that's it for this one. See ya.